1600.
It's the end of the world as we know it. I feel fine.
Welcome back. It's Dr. Fritz Gillette here, coming to you live from the studios of WWRL in New York City. We're on the AM dial, of course, at 1600, but also on the internet at WWRL1600.com. Again, we are live. This is a live show, open lines. I'm here with my co-host, Melissa Nicoletti.
And I'm rocking out to REM, End of the World, as we know it, because, well, nobody, I don't know if you've got plans for tomorrow, but apparently the world's ending. It's the apocalypse. So, yeah.
It's
I'm sleeping in.
It certainly feels like it, and it didn't take somebody's forecast to do
Seriously.
so. Seriously, one of the roughest weeks in recent
I'm
memory.
not a negative person, but can I tell you 2012 really stunk?
Yes.
It just stunk.
Tell me how you feel about that.
I can't because they'll bleep me. But yeah, like really, the world perfect note to go out on. Actually,
it seems like, you and I started the show a year ago, and we wanted to make it a place where people can call in and participate in the discussion, talk about what's happening in their lives, share their triumphs, and also.
Oh, thank you guys, by the way, for calling in and doing that.
So you can always do that.
Yes.
Lines are open 212-868-0975. But what's been hard, especially in recent months, is that it's almost like with a weekly regularity, we're talking about things that. You don't have the words to describe that.
They're unbelievable.
Unbelievable.
You could not make it up. And we've got people calling in from
all
places that were
world.
ravaged by Hurricane Sandy. We've got people calling in from around the world offering support. Right. I mean, it's amazing the amount of support and, on the other hand, the amount of devastation, really, that people have endured this year.
Until last week, I was in my office, and I flipped on the computer, and in between meeting with people. Now, I hear really traumatic and horrible stories all the time.
Yeah, I don't know how you do that.
And it isn't part of the occupation. You're supposed to be able to listen to people and hear what's going on with them. But then you turn on the internet and you see what happened in Connecticut. Mm-hmm. And I'm lucky I did have a break, because my first response, I'm sure like a lot of people, was a very human response as a parent. I have 2 children. And there were no words.
No, people were visibly crying. I know people that spent that whole weekend crying. I don't understand. And there's no why tragedies like that happen. And would that be something that people would be asking?
First thing we're always looking for. We're looking for answers. We're looking for a reason. And some of the first reports about the guy breaking into the school, well, not breaking in, but he was buzzed in, and then we hear that he shot his way in. I mean,
they actually blamed his brother. They had the wrong one, and that guy had to leave town.
And you all of us are looking for something, and that was a kind of school and the kind of town, the kind of place where none of us would have expected that could or would happen. It shaked us.
And, in the days afterwards, I understand the media has to cover it 24/7. In a way, that's good. In a way, that's good because people get to feel like there's answers. People feel like I guess they're constantly being fed information. But with that, there's a kind of an irresponsibility. And I don't know if you've noticed this. This actually makes me kind of angry that there's various, let's say, medical experts in the media that will suggest a diagnosis for someone that they haven't treated. So they say Adam Lanza shot all these people, and it was suggested that he had Asperger's or was on the autism spectrum. And of course, that infuriated people on the autism advocacy groups, because nobody's actually treated him that has come forward and said, hey, this is what he has. But people are suggesting based on, he exhibited some violent tendencies. It's like saying somebody had brown eyes and that's why he did that. And I know that people need to see why, but I think these diagnoses or these suggestions
a lot of that.
He's a sociopath. I mean, like, you can't.
It's driven by, a lot of times the networks are also looking for and hiring people to come in and speculate. And most of us are out there turning on the channel to try and get more information. And only the people who directly were involved with and actually sat with an Adam Lanza at one point, or knew his mother, or knew him directly, are really qualified to make any kind of statements directly about them. But we do this. All of us are turning on the channels, going on the internet, trying to get information. And why do we do that? Well, we're trying to make sense out of this.
Right, and we can't wait.
We're very
either.
disturbed by senseless acts. We need to find some meaning. We need to do something in order to feel better about it. And these sorts of incidences, especially this one, what can we point our finger at? And of course, the past week has been nothing but a discussion about gun violence and gun control, or a discussion about a failing mental health system, or a discussion about what was in her mind to be teaching, obviously, a disturbed person how to use all kinds of weapons.
Well, he was 20. She left him home alone for a couple of days. She obviously wasn't concerned enough that he was home with access to these things. I mean, she's the one that lived with him. She wasn't obviously worried for her own safety.
I wouldn't. Yeah, I actually wouldn't say obviously, because we never know.
Right.
I mean, he was 20, and maybe guns were in the house for his full 20 years. We just don't know.
Right. I know she was a gun enthusiast. I don't know that. It's been widely reported, but friends and people seem to have confirmed that she was a gun enthusiast who took her kids, taught them how to use the weapons. I would think that responsible gun ownership, it's something, if it's something you just raised with, like being on a farm around certain equipment, that it's not something like, ooh, I got a hold of a gun, let me go try this.
Why that day?
Yeah.
Why that day? What were the events that triggered that? And I think those are the things. You ever heard the story of Amelia Earhart? There's all kinds of stories and books and movies have been written. Whatever happened to her? One of the reasons why we still ask the question until today is because we don't know. And unresolved.
And our minds need to do something with that
Our
information.
minds need to do something about it. And our minds need to point the finger at something and advocate for something. And I for one, definitely a supporter of limiting these automatic weapons.
Okay.
What do you think about that?
Limiting the automatic weapons. I just don't understand what we need them for. I can appreciate, the people that say the Second Amendment, we have the right to bear arms, the government should get involved. What do you need one of these things for?
I can't answer that for you, except I think a lot of the people who do purchase those items are doing it for recreational reasons. I heard one quote, and it caused actually a bit of an uproar. Hey, maybe you have an opinion about it. Give us a call, 212-868-0975, 212-868-0975. I think a lot of the reasons people recreationally buy it is because it's fun. And I think that when it was quoted as saying that, and it caused a bit of an uproar.
No, I fired a BB gun or something in the backyard, and shooting target practice is kind of fun, but I don't have the desire to go on a rampage, and I also don't have...
Have you used a garden hose?
Yes.
Ever use a garden hose connected to a pressure washer?
No, but I think my husband would be all over that. That's a man thing, no?
That could be a totally other show, but we do have some kind of attraction to being able to shoot, whether it's a basketball.
Maybe we like the cause and effect, blowing stuff up.
It could be Freudian, too. You never know.
We do. I think we like the maybe the power of being able to blow something up or being able to alter it. That's why would anybody need a flamethrower? And yet we're allowed to purchase these.
Yes, there's a whole lot of things, but the point I want to make about even controlling something like automatic, there's so many things that the government already controls our access to, because they believe that even if we were trained in it, even if we could be responsible, if those things were to get into the hands of someone else who's not. And I think, again, Adam Lanza was 20 years old, so I'm going to make an assumption here that he had access to guns for quite a bit of time before he actually used it. And maybe she was the most responsible gun person out there. But there's some things that we probably should not own, because if they would have fallen into the hands of the wrong person.
Right. Well, it's kind of like having a liquor cabinet. Okay, we know we're not supposed to have it. The parents have locked it, taken the keys. You really think, somebody underage isn't going to get in there and get involved, drink, have a party when the parents aren't home or something. So maybe it's too much of a temptation, an attractive nuisance or something. I don't know how people grow up around guns and then suddenly just snap spraying.
There's a lot of people out there that have grown up in responsible gun ownership homes, and there've never been an incident. But these incidents seemingly are happening in greater regularity. At least we're hearing about it. Technologies are bringing it to us more often. I don't know.
So what happens now to Newton, Connecticut? Like, how do they heal this?
Then that would be the same.
No, and that's whatever they were known for before, whatever attractions in that town are now changed, and that's happened a lot this year. I mean, with Hurricane Sandy redefining the geography of the Northeast, it's just Colorado. People you don't want to go to a movie now. It's our world has changed, and it doesn't feel safe anymore. I'm sorry. I know
No, that's
we're uplifting here, but
Yeah. But it's honest.
It puts everybody on a sense. Maybe makes them hyper vigilant. Maybe you look twice at somebody. Maybe you check in on your neighbors a little more. Maybe you are.
Hey, but we could do something with this. We can raise awareness.
Yes.
Let's use some common sense here. Give the government, or a lot of people talking about putting more money into the mental health system. Okay, great. Let's do that. That'll help too. Putting some more controls over people's access to, I think, automatic weapons or weapons of mass destruction.
Absolutely. That outcome would have been significantly different if all he had was a handgun, right?
Yeah. There was a story about somebody in China going into a school. I think it was either before or around the same time last week. And
stabbing people or something.
And went stabbing people. Well, what if that person had an automatic rifle? Or that person had a gun? Guns are effective 83% of the time in suicides. When a person's pointing it at somebody else, pointing at their head, the percentages are higher. So as a psychologist, I can tell you, looking at the general population, people lose it. Now, what if they lost it when they had access to guns? And if everybody had guns, I think we'd have a lot more gun violence. Maybe you agree or disagree. Give us a call, 212-868-0975, 212-868-0975. Welcome back. It's Dr. Fritz Gillette here, and this is a WWRL. This is the Dr. Fritz Show. It's a live show. Lines are open, 212-868-0975, 212-868-0975. Last Friday, we were all traumatized to find out about the news and the events in Connecticut, and we want to have the guests here that are in the studio with us jump into the conversation as we talk about family caregiving. To my right in the studio is Gregory Johnson of Emblem Health. He is the creator and curator of this program. He helped put this together, assemble an awesome line of guests that have been here for 6 episodes and running, and tonight is no different. Welcome, Gregory Johnson.
Thank you so much, Melissa, Dr. Fritz, and our guests and our family out in the radio world. Since I was last here, I was sitting here listening to your lead-in in the first segment, and I couldn't help but make a statement to all of us. Since the Hurricane Sandy and then the great, great tragedy in Connecticut, and our love and our prayers go with these people, as with Sandy. It's very important for all of us to keep these people in our hearts, in our minds, and in our prayers. But one thing that I've noticed as I've been speaking in many, many places and doing counseling, the world, certainly here in our Northeast, has never understood family caregiving more than in these 2 tragedies. Families of choice have truly become something we no longer have to explain. It doesn't have to be a blood relative. We are all part of the human race.
We're taking care of each other.
We're taking care of each other. And as one of our very distinguished guests who's here this evening, Carol Levine, whom you will be hearing from very shortly, actually it was Carol who said, and I have quoted her many times, so I'm looking at her as I say it, a family caregiver, someone who shows up and stays to help.
Exactly.
And our other guest
On the line already.
on the line is the wonderful Gail Gibson Hunt, the CEO and founder of the National Alliance of Caregiving. And I'm only going to say one thing. We have with us tonight the first 2 ladies of family caregiving. Both of them have been mentors, are dearly treasured friends, and people without whose work, whose passion, and whose gifts and generosity to us, we would never have had the program at Emblem, nor would we have had the New York City Family Caregiver Coalition, nor the New York City Partnership for Family Caregiving. So thank you, ladies, for joining us, and I give them to you.
I got to tell you, if there was ever any way to get introduced, it'd be have Greg introduce you. We could loan you out to parties.
Anytime, Greg.
Hi, Gail. How are you? You there?
Yeah, I am. Hi.
Hi. So, Gail, you're president and CEO of the National Alliance for Caregiving. You're a nonprofit coalition. What do you do there?
We're an umbrella organization with about 40-some national groups, from running the gamut from federal agencies to membership organizations like AARP and corporate partners that we have, and we do most of the national research around family caregiving. And so we're the people that when, for example, Congress wants to know, how many people are really affected by that, then we try to come up with the answers for that.
Okay, so can you give us some numbers that you've been working with?
Actually, you used one of our numbers just in the intro about the...
yeah, but you're the source. Let's hear it from you.
$34 billion a year that it costs corporate America in terms of lost productivity, for example. We're talking about... Caregiving is really a widespread activity. We're talking about almost a quarter of the population is involved in this activity, and as Greg pointed out, not just for family members, but for friends and neighbors and extended family and other family of choice. So caregiving goes on very frequently in this population, particularly, although not exclusively, as people grow older. And I'm sure most of your viewers will be, especially if they're women, will be very familiar with the idea of caring for aging parents and caring for grandparents, as well as Carol is very familiar, caring for spouses
So
or children.
These numbers are also going up over time. What is it? It's in the multiples. It's 60 million, 50 million. How many people are affected by this?
That's like 65.7 million people.
That's
and
a lot.
About 65% of them are women.
Now, when you do these surveys, when you find how many people in a population are family caregivers, how do you find these people? How do you find this information?
It's typically, if it's a telephone survey, it's a random digit dial. I mean, literally, you call the survey research firm calls thousands of households and asks if someone in the household is caring for somebody with a disability or a long-term illness. And then you add them up until you get at least 1,000, and then that's going to be statistically representative of the U.S. population. Or you do an online panel, which isn't quite as random, but the concept is the same. The idea is that you have to do lots of outreach in order to get those 1,000 people who really represent the...
And you have to do a lot of outreach because people don't necessarily self-identify as a family caregiver.
Yeah, but we get around that by not ever asking right off, are you a family caregiver? Because you're right. You wouldn't get... people would say, no, I'm just doing what any good daughter would do.
Okay, so we have people listening right now, and we're really trying to get this information to them and motivate them to identify and take part. What can you say to them to ask the question, that is?
Well, first, they need to understand that they're not alone, and there is help out there, and they need to take that first step to reach out and ask if there are resources in their communities. And many communities have resources, although with the economy being the way it is now, it's fewer communities and fewer resources in even the resource-rich areas. But there's definitely there's services out there. There's something called the National Family Caregiver Support Program, which is about 10 years old now, 11 years old, and they offer federally funded information and referral services, just as one example. And they have an 800 number, which I'll give you anyway, 1-800-677-1116, and that's the elder care locator. And if you aren't caring for somebody who's older, they will be able to hook you up with the local resources that are available for somebody who's younger.
And it's interesting, Gail. You're working on, let's say, a national level to increase public awareness. Yes.
Yes.
Okay. So you would work with local governments as well to give them these figures and give them the information that they use in order to help develop their programs, right?
Actually, we just work on the national level.
On the national level, okay.
Yeah, although there are about 95 caregiver coalitions, state and locally, that we have worked with. But those caregiver coalitions are responsible for coming up with their own data. Mm-hmm. And the New York City Family Caregiver Coalition, which Greg helped to co-found, is a good example of a local caregiving coalition. And
interestingly, someone who says they're a big fan of yours, Robin Finley, who works for the government, local government. If you're here in New York, you can call 311. The Department of Aging, get Robin Finley on the phone or one of her colleagues, and you can actually call the government and they will help you if you are a caregiver, if a family caregiver, if you are working with elderly. They have a ton of resources, and I think people underestimate the role of government, that it's too big or it's overwhelming and they can't get the information. But there are people there
trained for this, who've trained to be there to answer your questions.
And they can hear Robin actually on one of our earlier podcasts.
Yes.
She's really a good example, I think, of the kinds of resources that are out there. Mm-hmm. So people just need to understand that they have to do that first step of identifying themselves and then realizing that they're caregivers and then just looking for caregiving resources. And they're on the Internet. There are many, many caregiver websites that either are for specific issues like Alzheimer's or are really broad like caring.com and care.com are just two examples.
Have you seen improvement in the public's perception of caregiving?
Oh, no question. I think there is a lot more awareness. You see so many newspaper articles, television shows that reflect an increased public awareness. That hasn't exactly translated into policy at the federal level, I think. We don't see a lot more investment in caregiving programs at the federal level, like caregiver assessment, for example, asking the caregiver whether or not they are willing and prepared to be the family caregiver, say, when somebody's being released from the hospital.
Ah, yes, sometimes they just end up being that way.
Yeah, the doctors and the discharge planners, and they just assume that this person will take this on. I mean, Carol is very familiar with that.
Yes. Right, and we were actually going to get Carol's story soon. About yeah.
Okay, but we're getting close to a break. Okay, we still got a little bit of time. So what you're saying is what more needs to be done is at the national, federal level of getting some of the policymakers to put some things in effect.
Yeah, to put more in effect, and there's a real tendency now in Congress, because I think they're obviously concerned about the budget, to say, well, let's discharge people more quickly from the hospital. Let's send them home, and we'll just assume that a family caregiver can take on more and more responsibility. For example, with devices and respirators, and actually expecting that they can offload the tasks that perhaps the health care system should be doing. They're offloading it onto the family caregiver, who's typically not paid.
And not trained.
Just sending someone home.
Not trained.
Mm-hmm. Just sending someone home with a bag of medication or something. Here you go.
Yeah, and a discharge plan that just assumes that all of somebody's post-stroke, for example, that the apartment is accessible or the building is accessible, and has everything that the patient the care recipient really needs, and it's really left up to the caregiver to make all those arrangements. Some people, obviously, are long-distance caregivers, and that presents certain challenges that the day-to-day caregiver that's right there doesn't have. And there are also some...
That would probably be very frustrating as well.
Oh, yeah. Well, then there's a big impact on their work because you're taking off time from the office. You're going to travel a distance, fly maybe, to visit your mother like once a month. And you think you've got these services arranged, and they're going to be in place. There's going to be somebody to look in on her and somebody else that's going to do meals, and then you arrive back, and wow, all the sort of services you've arranged sort of fall apart. And then what do? You're the long distance. You're back 3 hours away.
Gail, we want to thank you for calling into the show tonight. And we're back here. Dr. Fritz Collette here, live at the studios of WWRL in New York City. We've got a phone number here that you can call in and participate in the discussion we're having about family caregiving or whatever else is on your mind. 212-868-0975, 212-868-0975. Again, jumping back into the conversation about family caregiving. We are all family caregivers. We've had quite the rough year, quite the last few months. And Greg Johnson, who spoke earlier and is still here with us in the studio, made a great segue into the topic that these events have really reminded us how we need to take care of each other. We are part of something bigger than ourselves alone. And so I'm glad to have Emblem here sponsoring this series, and we're talking about family caregiving, but we're talking also about you and me taking care of each other. Now, one of the questions I keep on putting out there, because I was a family caregiver who didn't know he was a family caregiver, who went to an event sponsored at Emblem earlier this year, and it was when I'm sitting there in the audience, just as a doctor going to a healthcare event, realize, wait a minute, Greg Johnson, he's talking about family caregiving. He's talking about me. I've been taking care of, helping my mother take care of my father for the last 4 years, 4 or 5 years, if not longer. And I really didn't know. So some of you may be listening out there and may not know that you're a family. Yeah, you take care of somebody. But what we're trying to do is find the words that are going to get you to access this information and, grab the booklet that Greg and that we've been talking about is here. So we have in the studio here Carol Levine. Can you help me with the language that can motivate somebody to go, hey, I'll bear witness, I'm a family caregiver?
Well, I can't give you the actual words to say, but I can only
brainstorm together.
I can tell you that your experience of not recognizing you're a family caregiver actually mirrors my own experience, because when my late husband, was terribly injured in an automobile accident, and I was left to take care of him at home. He was essentially quadriplegic with traumatic brain injury, very complicated care. I didn't know anything about family caregiving, even though I worked in health policy and had a lot of contacts. It was only about 5 years later that I started doing some reading about it, and then I came across this term, informal caregivers. That's a policy term that means you don't get paid for what you're doing.
But you're somebody that Gail was talking about.
Yes.
You get sent home with here's some needles and a machine, and go ahead and do the job.
Informal was the way the policy people tried to distinguish the families, or however they were defined, from all of the formal caregivers who are the professionals. So I said, wait a minute, informal? That's a picnic. That's fun.
I'd love to be informal.
This is not what this is all about.
This is serious.
This is hard stuff.
Yeah.
So over the years, the term informal caregiving, you still see it, but you see it in research. You don't see it in real discussions. What I think is hard for people is they feel that if they acknowledge that they are doing caregiving, by that I mean personal care, household chores that they would not ordinarily do, and as Gail mentioned, and as I know very well and have studied, the kinds of medical nursing tasks that 10 years ago, 15 years ago would have been done only by trained nurses or doctors in hospitals or nursing homes. That whole range of things that people need to have done because they can't do it for themselves. So if you think about the tasks of caregiving, that's one way to look at it. What people are afraid of, I think, and don't want to acknowledge is that if they say, well, I'm a caregiver, I'm doing one or more of these things, then that somehow takes away from your primary relationship, which is daughter, son, spouse, whereas it's really not. That relationship never changes. You are always going to be that person. It's the caregiving is a job. It's a job you've taken on. If you look at it that way, it's not as threatening. So I try to ask people, "Oh, I'm not a caregiver." Well, what do you do for your mother? Well, I take her to the doctor. I pick up her medications. I make sure she does her medications. I do all of, sometimes I have to change the dressings on her
That's
on
a
her wounds.
big deal.
And okay, guess what? You're a caregiver. And then you kind of get to don't start with you're a caregiver, start with what you do. But make sure that they don't think that doing that takes the primary relationship away. That's my only way I can explain it.
That was awesome.
Well, that it does help people.
Yeah.
Because you don't want to divide them up. You don't want to say it's only this or only the other.
Yeah,
Does that help?
That helps a lot.
Okay,
Because
good.
those roles, I mean, we're involved in those roles.
Right.
As children, we help out our parents in various ways, and as we get older, the things that we're doing for them increase.
Exactly. And they increase, and they're things that you would not have anticipated doing. I must say, if it's personal, it's a personal feeling on my part. I don't like to think of parenting your parent, that somehow you've totally reversed roles. I will always be the mother to my children. I was always the daughter to my mother. The relationship changes, but it doesn't mean that you now have to treat your old mother as a child.
Right.
That's something that I think people get a little concerned about as well.
So we see it as just a new chapter in
Yes,
an evolving
I see
experience.
it as an evolution, and that
Right.
it changes even within. You start out doing caregiving, maybe it's very simple stuff, and you don't have to do all that much, and it's not a big responsibility. And then something happens: the crisis, the fall, the stroke, the bad diagnosis, and then things change. And you just, you work your way into it. So it's a dynamic situation, and it being reflective of the change and being aware of the change is really important, because your need for resources and your need for help change. So what you need at the beginning is not what you need 2 years later.
And what I found most helpful is as you accept or even recognize that we are part of something larger,
Yes.
and we talk about it. We express our concerns to others, to friends. I mean, I've had lots of support from friends and family who I've told about this process, and I've gotten things from wheelchairs or special equipment or places and ways to get instruction, and that's how I found Gregory Johnson. That's how I found what you guys are doing.
Yes.
Now,
yeah.
here's a question,
Yeah.
Dr. Fritz. Would you say there's a difference between, let's say, caring for an elderly relative or somebody who you've kind of watched, you know them that well, and someone in Carol's situation where suddenly there's a traumatic incident and suddenly her husband's discharged from the hospital and they say, okay, Carol, here you go, change the dressings and here's the medication. And I mean, thank God she had the wherewithal, having been in health policy.
Sometimes we slip into the role quite dramatically, and sometimes it's a gradual process.
Right.
I think for a lot of people, when they slip into it traumatically, or it's an accident or something like that, it's more demonstrative. We know that's the role we're slipping into, but a lot of people gradually go into that role
Yes.
unknowingly.
I think that's probably more typical,
Right.
that it's gradual, and particularly these days where dementia is and cognitive problems are so common. It's not that there's one day where, oh my God, something is wrong with my mother's memory. It gradually happens, and unless you're really paying attention, you're not sure. But there's always some event. Something happens, even that kind of forces the awareness,
Right.
and then you start thinking this is a new chapter in the relationship.
Well, I think that's what's so important about being a family caregiver is you have such insight and
Exactly.
to offer, let's say, their primary health care provider, that you
Exactly.
can speak to the doctors and the nurses and say, I've noticed this small change.
Exactly. I've worked over the years with Dr. Jeffrey Nichols, who's a geriatrician, and he has always said healthcare professionals, and he included himself, a doctor, he said, we think it's all about us. It's really not all about us. It's about the family. That we send them out of the room, but they are the ones who know the most about this patient, and we need to listen to them. And that's right, because family members can pick up subtle cues about changes in the patient's condition. They know that they've taken this medication before and they had a terrible reaction to it, or they know that they're not going to swallow this big pill. So those are really important pieces of information. I often say that the family caregiver is the only historian of the patient's illness, the only one who's been there from beginning to end and really knows the whole story. Everybody else does a little piece of it. They come in and they go out. But the family caregiver's there. You're there. You're part of it all the time.
So if you're just tuning in with us, we are with Carol Levine. She directs the United Hospital Fund's Family and Healthcare Project, which focuses on developing partnerships between healthcare professionals and family caregivers, especially when, Carol?
Especially in times of transition. And when we say transition, we mean changes when in healthcare settings. So it's hospital to home, hospital to short-term rehab to home, maybe one of those to hospice, where there's a home care agency. And as the healthcare system has changed over the past 20 or so years, and particularly more recently, people go through these like revolving doors. They're in and out of all these different places. And transitions are the places where mistakes happen, communication doesn't happen, and things fall through the cracks. So we are trying to make those transitions more seamless by involving family caregivers who are going to be responsible at the end and know what's been going on and what should go on.
Because we talk a little bit about how those transitional errors take place.
Well, the most common one is the most common errors around medications. People go into the hospital and they may or may not have a complete medication record. So a lot of medications are discontinued because they're not needed for the acute care illness. But then they're never restarted. So when the person goes home, they should be on their basic stabilizing blood pressure medication or whatever.
Sure.
In hospitals, they have their own, what they call formulary, the list of drugs that they prescribe and they use. Because they buy them in bulk. That's the reason.
Okay.
And then when you go home, the prescription is for something else because that's what the insurance company covers. So people are taking double doses, or they're taking no doses, or they're taking them at the wrong time, or they're taking them with food, without food, because no one has spent the time explaining all of this to the family caregiver. I can't tell you how many times people will say, well, I told your mother about what her medications are. Mother is demented. Mother doesn't know what day it is, much less what medication she's supposed to take. So that's the most common thing. It's the rush to get people out of hospitals. And the failure to include the family caregiver. The Institute for Health Care Improvement says the patient may not be the key learner. the family may be the key learner. And that's what we're
So-
trying to work with
And the
providers to
healthcare
do.
provider also has to be aware of how to teach the family
Yes.
caregivers.
Right.
Yes.
Again, don't release them from the hospital with a bag of medication and say, okay, go. Or in your case, you said you're talking about a machine, and then the one that they
Right.
showed you in the hospital is different than the one that your insurance is
medication's
covering. And
different.
yeah, the medication's a different color.
Exactly.
Yeah.
And because they're being released from the hospital earlier than ever, or quicker, the family caregiver, I think you were saying before, is doing more complex tasks.
Yes,
Let's talk about
in
that
fact,
a little bit.
we did. Gail is right. The National Alliance for Caregiving does huge number of surveys. We did one too with AARP, which is released and called Home Alone, and it's on our United Hospital Fund website, www.uhfnyc.org. And it was an online survey. We found that 46% of all the family caregivers surveyed were doing some kind of complex medication management or wound care or monitoring equipment or doing care coordination, all of the kinds of very difficult tasks.
That can be really overwhelming. Suddenly you have to give someone an injection. Or, I
Injection.
mean, I don't know. If my husband had to do that, we'd have to get a caregiver for the caregiver. Thunk.
Yeah, it's and you know it's been interesting. The professionals who see the report say, well, we know that, and we're not surprised about that. Yeah, but family caregivers are surprised when they have to do this because they think that's what a nurse should do.
Right. So now, if you find yourself suddenly with a bag of medications
Right.
and a machine you've never seen, what can you do? Ah,
Well, one of the things you can do is go to our website, www.nextstepincare.org. That's the website that we've created that has a long list of guides for family caregivers about specific situations, going home from the hospital, whether you should go to rehab or go home, what home care agencies really provide and what they can't provide. And there are medication forms and a guide to medications that help you. They don't give you the specific answer to every question, but they give you the broad range of questions that you have to ask. Knowing what questions to ask is the first step. And we don't know what to ask in the beginning.
no, but I think if you're in charge of someone's care and they're in
Yeah.
the hospital and getting to be able to have your guide, getting to nextstepincare.org,
Nextstepincare.org.
and being able to say, hey, this is what I should be asking the doctors.
Right.
This is what I need to
And,
know.
and don't,
That's
you know,
helpful.
you can say in a hospital, this is not a safe discharge. You cannot discharge my parent home because I don't understand what I'm supposed to be doing and I'm not going to be there every day. It'll get you a little time, but you need to be assertive for yourself and say, I'm a family caregiver. Now I know that, and I have rights, and part of the rights that are, that is federal. I have a right to be involved in this discharge. I have a right to know what's going to happen. These are things that are important. Let me also say it's not easy to be that person in a setting where people are pushing you to go home. But if
There's
you
a lot of
really,
pressure.
Yeah, there's a lot of pressure, but you can do it, and you want to do it because this person's life depends on it. This is not a joke. I mean, this is really serious business. You take somebody home and you're supposed to clean the wounds, post-surgical wounds. You don't do it right, they get sepsis and they're back in the hospital, which is the other side of I just want to mention that, yes, they're going home from the hospital faster, but there's a great push now and financial penalties associated with it if people come back to the hospital within 30 days. So there is some financial reasons that hospitals are now taking discharges a lot more seriously.
So looking at the bigger picture, what more can be done to inspire this process?
Well, I think that we have learned that once providers work together in teams and look at what they're doing and look at what the benefits of including family caregivers in the medication process, in the discharge process, they see that families are not just nuisances, but they are real help. They can really ensure a safe transition. I think there needs to be a lot more attention at the federal level and at local practice levels of developing ways to make those partnerships real. And we've been working in New York City with 40 different organizations who have made tremendous progress in doing that. Can be done. It takes the phrase that everybody uses, but it takes a culture change. It takes a different way of looking at family members, not just as visitors, but as partners in the team. And then it does make a difference.
I think everybody has a lot of people actually have a story like that. I know my in-laws, my brother-in-law has been caring for his parents for years, and it's just sort of accepted that that's the role he fills. And people drop by for the holidays and whatever, and parents have health issues, and everybody really, I mean, as a family, should be assisting, sharing the care, as it were. And it's hard to, when someone's got that role, to ask them, do you need anything? Because they're used to saying, no, I got this, I'm used to it, you don't understand the medication. I think it's hard for caregivers to give up a little bit of the control, because they're used to doing it.
Hard for caregivers to give up control, give up the role. It's hard for patients to accept that someone else might be able to do this too. So it's not easy. I've always found that it's not enough to say, "Can I help you?" What people should say is, "I'm going to do some shopping and I'm going to bring you some dinner. What would you like for dinner?" Something very concrete. Or, you haven't been to the movies in a long time. I'm going to come over. What day would you like to go to the movies? People are more willing to accept help if it's limited and if it's very concrete.
Right.
All right. So let's talk a little bit about in the bigger picture, because we only have a few minutes left. We've got Greg here. What more can be done? 1 minute.
Keep listening to these wonderful iPads. Truly, we've had the privilege of having the New York City Partnership for Family Caregiving Corps. All of the major partners, Friends Indeed, Share the Care, Marian Gambardella and her support group, SAGE, Aging in New York Fund, and Intersections International, along with today's two extraordinary guests from the National Alliance of Caregiving and United Hospital Fund. And there's not enough I can say about Next Step in Care. It was a lifesaver for me. The point is, none of us trained for it. The point is, none of us knew we were going to perhaps even play this role. But the best news is you are not alone. And that's the message we want to get into the corporations, so that we can bring help to the people they call employees, and we love and adore because they're fellow family caregivers.
Well put.
Well put.
Thank you, Greg. Thank you, Greg Johnson.
As always, Greg.
This information from just being here and listening to all the guests have been enormously helpful to me personally. Do what Greg says. Download the podcast. Listen to them over and over again. Share them with people. There's information here that can help you. We're all in this together. If nothing 2012 has shown us is that we're all in this together. We're all family caregivers. So I want to thank our guests here. Again, the drfritzshow.com is a place where these podcasts are housed. You just go there, you click on some buttons, and you will be able to listen to that and share that with other people. Follow us on Facebook and Twitter. And any parting words? Melissa, here we got 1 week before the holidays.
1 week before the holidays. Well, I guess next week we'll be talking about our resolutions. We're going to have a lot of fun because this is, 2012 has really just sucked. Can I say that?
On behalf of Emblem, let me just say thank you, Dr. Fritz, and thank you, Melissa. You've been wonderful. And to our film crew, because we've been filming this.
So I have to wear makeup every week.
Sound crew. Thank you so much.
We'll be back again next week at 10 p.m. This is the Dr. Fritz Show. We've been on the air a year, and this is what we do. We try to bring you people and information and practices to help you live your better life. And I'm a psychologist. What I do is I listen to people all the time. I spend a lot of time even during these episodes listening to the experts that come in here to talk about what we do. And what we want you to do is listen to it, share it with people that you know are in need. These are tough times in our world, and we need people to get out there and inspire us and keep us going. So again, we'll be on again next week, Thursday night.